Well, good morning and welcome everyone. Appreciate you joining us today. I'm Jean Blake. I'm your CEO. We are changing things up a bit this year and having our special guest present prior to the annual general meeting, as Dr. McKeown is speaking to us from Shenzhen, China, where it's 12:30 p.m. at night. So in order for him not to stay up even later, we are having him speak first. So I'm so grateful that you fit us into your very busy schedule over there, Dr. McKeown. And for me, it's very special to have you as our guest speaker today, as you came on board as the medical advisor to the board and the society shortly after I joined the society myself, a little over 10 years ago. So I'm so appreciative that you're here today to provide this reflection on the last 10 years and looking forward to the next. I'm going to talk a little bit. Probably a lot of you know who Dr. McKeown is, because he is a BC and Canadian celebrity. He's the John Nichol Chair of Parkinson's Research and professor and head of the Division of Neurology at UBC. He has a wonderful background combining both engineering and medicine, and has been really instrumental in some very unique, exciting, and creative research studies with that blend of backgrounds. His formal training was at McMaster University, the University of Toronto, the University of Western Ontario, and the Salk Institute for Biological Studies in San Diego. He was also on faculty at Duke University before he was recruited to UBC here. And he is currently the Chair, Research and Clinical Advisory Committee for Parkinson's Canada. His research interests include privacy-compliant video disease monitoring technologies and non-invasive neuromodulation as a novel treatment for Parkinson's disease. So welcome, and thank you again for joining us so late at night there in China.
Right. Well, thank you for that kind introduction, and I appreciate you accommodating me so that I don't have to stay up too late. It's certainly been wonderful working with Eugene over the years, and I've been grateful to be able to participate with Parkinson's BC. We're always very supportive of this wonderful organization, so I'm very happy to give this talk today. But it is a daunting task to try and come up with everything. I'm undoubtedly going to miss some things, but I've tried to come up with a summary of some of the things that seem to be quite important that have come up over the last 10 years. And of course, looking forward, no one has a crystal ball, so that's always going to be fraught with potential error. But there's certainly lots of very exciting things that I see on the immediate horizon, and a lot of my colleagues share with the excitement. So I've tried to provide a brief summary of some of these things. So this is a very brief outline. I'll talk, basically divide the last 10 years into new ways of diagnoses and also new treatments. So let's look at the last 10 years and specifically look at new ways to diagnose the disease earlier and more sensitively and more accurately. And one of the big things that everyone has known about has been the revolution in knowing about the genetic contributions to Parkinson's. And you know, the reason why we study genetics is not because it's the most common cause of Parkinson's, but it tells us which biological pathways may be involved. So for example, if a specific gene encodes for a protein like alpha-synuclein, and people who have mutations in that gene develop Parkinson's, then it tells you that the protein alpha-synuclein must be important for the disease. And so it's estimated that about 10 to 15% of cases of people living with Parkinson's have a clear genetic cause. However, it may be more nuanced than just one gene equals the disease. That's as I said, fairly rare. Very often it's an overall genetic burden where it may be a complex interaction of many genes. And so far they've identified over 80 genetic loci that appear to be associated with increasing the risk of Parkinson's. And this just keeps growing every year and will continue to grow. And the most common ones that you will hear would be things like GBA, LRRK2, SNCA. And the reason why these are very important, as I said, is the SNCA gene encodes alpha-synuclein, and this is an abnormal protein that gets deposited in the brain and affects the dopaminergic neurons that cause premature cell death of these dopamine secreting neurons. And so a lot of new therapies that I'll talk about later are targeting this abnormal protein alpha-synuclein. So that was one clue that came with genetics. The other thing is that the GBA mutation is opening up the door for what we call precision medicine. So if the disease is caused by a specific mutation, then there are developing therapies that may target that particular mutation. So, for example, it's not so it wouldn't be an overall treatment for Parkinson's. There might be a treatment that would only work if you had this one particular mutation. So we may see this more in the future. The other thing that has been a big thing in the news in the Parkinson's world is that a lot of the early genetic studies were done in people with North European ancestry. And so a lot of the families that were done, a lot of the studies that have been picked up have detected all of the genetic markers of Parkinson's in that population. As they've now expanded globally, they've discovered in different populations new areas or new genetic loci that seem to be important for Parkinson's. So one thing that was recently discovered, I think in the last year or two, was this novel mutation that was found in 50% of people in Nigeria with Parkinson's. So again, it seems this may give us more insight into new pathways as we look not just at European ancestry, but look at the Asian populations and the African populations. So this may give us new insight. So this is going to be a very hot topic, but it's certainly been something that's been important over the last 10 years. The other thing that's important is instead of some genes just causing the disease, where if you have the gene, you have a very high likelihood, there may be some genes that actually modify the disease severity. And so, for example, if you have one of these genetic mutations called a GBA variant, how severe the disease is and how early you get the disease appears to be dependent upon some of your other genetic factors. So these are not just causative, they may also be affecting or modifying the disease severity. And so this seems to be something that has been discovered and is being actively pursued. One thing that is another switching gears here a little bit is there's been a lot of interest in biomarkers. So with Parkinson's, like all neurodegenerative diseases, the earlier things are picked up, the better. It is known that by the time someone presents with tremor, for example, or some of the early clinical manifestations of Parkinson's, they may have lost up to 50% of their dopaminergic neurons. So as we get new therapies that may protect these neurons, obviously the earlier we catch it, the better. So there's a lot of interest in detecting the disease as early as possible. One of the things that has caused a lot of hype or have got people very excited is this thing called an alpha-synuclein seed amplification assay. And basically what it is it's a way to greatly amplify very, very tiny quantities of this abnormal protein that I mentioned earlier, this alpha-synuclein. The slight downside is that it has to be obtained with a lumbar puncture or a spinal tap. So it's not as easy as getting a blood draw, but it is a very simple and safe procedure that can be done in the outpatient clinic. So it's not an insurmountable hurdle, but it's certainly a bit more involved than getting a simple blood test. But what seems to be very important about this is it seems to be highly sensitive and specific for Parkinson's. And the exciting thing also is that it has been detected in people with so-called prodromal individuals. In other words, people who have no clinical signs yet, but have some changes in this assay, and then later on go on to develop Parkinson's. And so this raises a possibility that I'll mention in a little bit of when does the disease actually start, and do we have to redefine, what we mean to make a diagnosis of Parkinson's? Because obviously, as you mentioned, the earlier we detect it, the better, and we may want to detect it before people show any signs whatsoever. So, and the other thing that has been very good about this particular assay is it also seems to correlate with disease severity. So if, there's a lot of interest in quantifying how the disease is progressing. So for example, if you have a new treatment and you want to know whether or not this new treatment slows the progression of the disease, you need to have some sort of quantitative way to tell you how severe the disease is. And there are many different ways to do that, from PET imaging to blood markers to clinical scales where we have people do clinical tests. But this would be another way to quantify how severe the disease is. And so that could be used to monitor new therapies as they come online. And it may also be used to subdivide people. So one of the challenges in Parkinson's disease that many of you know is that it's not a single homogeneous disease, and it varies tremendously from individual to individual. It progresses at different rates. As many people with Parkinson's compare notes, they may notice that what's true for one person may not be true for another. And so the other benefit of this assay seems to be is it may provide a way to stratify people into different subtypes, because different subtypes may respond differently to different therapies. And so this stratification may be extremely useful. Another assay that has not quite had the same hype associated with it, but may be just as important, is this dopa decarboxylase, which again must be obtained through a spinal tap or a lumbar puncture. And it's similar in that it's positive in clinically unimpaired individuals. So again, this is exciting that you can take someone who has no symptoms whatsoever, and if this assay is positive, then you can say that this person is at great risk for going on to develop symptoms. However, the downside of this one is it wasn't as specific as the other assay, where it did not reliably differentiate between some of the different things of some of the other types of Parkinsonism. So this one isn't quite as accurate as the prior one, but all of these are being investigated now, these new types of assays. And basically they're developed on the technology that enables us to detect very minute quantities of abnormal proteins or other molecules in the cerebrospinal fluid. Okay, sorry, just a second. There we go. Another thing that's come up, and this is a little bit like a tool looking for a problem, and that is there is this technology which is called OCT, or that should be, sorry, optical coherence tomography. And what this is it's a very non-invasive and simple way to look at the cells in the back of the eye. So one of the things that we teach medical students is very often for part of the neurologic exam, they would use an ophthalmoscope to look into the eye. And you would say, why is that? And that is because that's the only part of the body where you can see the blood vessels and see part of the brain. Because the optic nerve comes in. And so if you look at these different cells in the back of the eye, it could be detected with this optical coherence tomography technique. And what it does is it just shoots a simple light, and the way it reflects back, they were able to determine. And what they've shown is that in Parkinson's, there's thinning of these different layers that you see here. You can see that there's these different cell layers, and all of these layers have been shown to be altered in Parkinson's. And this technique is actually used not just for Parkinson's, but for many brain diseases. It's being looked at for MS, it's being looked at for Alzheimer's, and so on. Because it's a very simple technique. You just, have a flash of light that goes in the back of the eye, and boom, you have a way to assess the nervous system or parts of the brain. So this is being investigated for many other diseases besides Parkinson's, and so it may be useful. Another thing that's being examined are these things called extracellular vesicles. So these are small vesicles that are floating around in our blood. They are naturally released by all types of cells. And one of the big challenges in all brain diseases, which I'll talk a little bit more in the future, is this idea of the blood-brain barrier. And the problem is that in order to protect the brain from any sort of circulating toxins or infections that may be in the blood, there is this barrier called the blood-brain barrier to sort of protect the brain. And that's good that it's there, but the downside is sometimes it makes it very difficult to get medications into the brain. And also, it's very difficult to detect abnormal changes in the brain from a blood test because this blood-brain barrier is there. But these extracellular vesicles do cross the blood-brain barrier, and they seem to be more stable than other blood tests. Some other blood tests can go up and down. For example, if someone has a cold or a flu infection, you can get a spike in these values, and so they tend to be very kind of noisy. These tend to be a little more robust. And, some early studies have shown that these changes do seem to follow disease progression. So this might be another quantitative way to assess disease progression. Now I'm going to switch to a little thing, which is a very active, hot topic that was just published a couple of months ago, and includes our colleague, Dr. Stossel. And in fact, if you look at some of the authors here, the Canadians are very well represented. So Dr. Postuma is a professor at the McGill. Professor Lang is a professor in University of Toronto. Dr. Stoss, of course, is here at UBC. So these are kind of many of the world experts, and they have tried to come together to come up with a new definition of Parkinson's. In fact, they said maybe we need to rename the disease. Now, why would you do that? Well, again, as I mentioned, by the time people show clinical symptoms, the disease has already progressed quite far along. So it gets into this big dilemma of when does the disease actually start? And when can we give a label to someone and say, yes, you have Parkinson's, even though you have no symptoms? So this is an ethical thing. It's caused a lot of discussion. Because you don't want to give someone a label saying you have Parkinson's because they have some of these early changes that never go on to develop Parkinson's. So an example of something like that would be loss of smell. It's known that sometimes people can lose their sense of smell many years before they go on to develop Parkinson's. But you wouldn't want to say just because you've got loss of sense of smell that you've got Parkinson's, because there's a lot of people who lose their sense of smell and don't go on to develop Parkinson's. So this is always the dilemma. But on the other hand, if you had a new treatment, let's say that targeted alpha-synuclein, this abnormal protein, you couldn't ethically give it to someone unless you had said, okay, you have the diagnosis of Parkinson's. And so, there's a desire to have an accurate diagnosis, but an early diagnosis, and how you balance the accuracy and how early you make it is part of the ongoing challenge and part of the discussion. So this group has proposed what they call synergy, and they argue, and for now, this is purely for research. So it's not going to be implemented in the clinic, but this is the way the field is going. And they basically argue that there should be three core biological factors that would make you feel confident that even though someone has no clinical symptoms, they do have Parkinson's disease. And one of them is this presence of alpha-synuclein, this abnormal protein. If you don't have that, it's hard to say that someone has Parkinson's if they don't have evidence of this abnormal protein. And there must be evidence of some of the brain cells, or some evidence of neurodegeneration. If there's just the protein but no neurodegeneration, we couldn't call that Parkinson's. And then also some evidence that there has been some genetic, at least risk factors. If someone had absolutely no genetic risk factors at all, it would give someone pause about feeling confident about making the diagnosis. So their argument is that these three components would be important to ultimately make a diagnosis of Parkinson's disease, even though they may have no clinical symptoms. And that would give you enough confidence then to go on and start treating them, even though they had no symptoms, to try and prevent any symptoms from later on occurring. So I think this is a very active area of discussion. You'll hear a lot more about this in the future, especially as new therapies are becoming available. For example, a little bit later, I will talk about therapies that are targeting this protein alpha-synuclein. And so obviously, if you want to give someone these powerful drugs that are targeting alpha-synuclein, you better be confident that you've got the correct diagnosis. So I think, as I said, we'll be hearing more about this in the future. Now let's talk a little bit about treatment. I know that Parkinson's BC is very familiar with Duodopa because Jean and I and a few others went to meet the minister to try and lobby hard to get coverage of this therapy in BC. We were one of the last provinces. So what this is that, the natural state of dopamine in the brain is it's relatively constant. And if you take pills, you take a pill, the medicine gets absorbed. And after it gets absorbed, then the body metabolizes it and it wears off. And there are some people that we call having brittle Parkinson's, where they have a very difficult time, where it's very easy for them to get too much levodopa, where they may get levodopa-induced dyskinesias. And then if the level drops just a little bit, they don't have enough levodopa and they can get wearing off and be very stiff and slow. The difference between too much and too little is what's called the therapeutic window. Early on in the disease, thankfully, that window is very large. And that's why there's a bit of a honeymoon period early on in the disease, where people can be a bit sloppy of taking their medicine a bit early, a bit late. It doesn't really matter. They don't really notice the medicine wearing off if they forget a pill. Unfortunately, as the disease progresses, that therapeutic window between enough medicine and too much medicine gets very, very narrow. And for some unfortunate individuals, this window is so narrow that it's almost impossible giving medication low doses so frequently that we just can't, with pills, manage to control their Parkinson's. And so for those people, the Duodopa has been a real benefit. And what this is essentially a liquefied form. It's an intestinal gel of levodopa. and it's continuously pumped into the gut. But it requires that you have a day operation to insert a tube that goes through the abdominal wall into the stomach and then into the jejunum. And this is exactly the part of the gut where levodopa is absorbed. So what it does is it directly infuses exactly the part of the gut where the medicine is absorbed. And this has been a real game changer for people who, as I said, have very brittle Parkinson's. It's certainly, I think, being transformative to many people who've had this. So you have this cassette, and then you have this pump that then continuously pumps in the medication. This is the pump, and then this is the intestinal gel that then is swapped out, and you swap in these different cassettes as the gel is used up. And because you must carry this pump with you, there's different ways that this can be managed. There's different bags and waistcoats and so on that you can wear in order for it to be less cumbersome. One of the things that's been a bit of a surprise, actually, though, was the high incidence of what we call peripheral neuropathy. Now, what this is that, we all have nerves, which are the telephone wires that go down our legs that allow the muscles to move and also provide sensation to the lower limbs. If those peripheral nerves get upset, you can get things such as loss of balance and some burning in your feet. And this might be a sign of what we call a neuropathy. Now, it has been known for many years that people on levodopa, especially high doses of levodopa, for many years may develop a peripheral neuropathy. And it's thought to be deficiency of the B vitamins. And so it is often prudent, we tell people who are on levodopa for long periods of time to take a multivitamin or a multi-B complex vitamin specifically for this. But what I think was a bit of a surprise was that once we continuously infused the levodopa gel in with duodopa, that the rate of peripheral neuropathy went up quite a bit more than what was anticipated. And so now pretty well everyone on duodopa is just given a B vitamin. Like we often don't even measure the levels because we anticipate that they would be low. So I think it's recommended that everyone takes a B vitamin. So that was a bit of a surprise. And it's something that we have to be vigilant about. Occasionally, it can come on very quickly, and so there is something called Guillain-Barré syndrome, which is not Parkinson's, but it's a rapidly progressive neuropathy where the numbness can come on very quickly, and so that has fooled a couple of clinicians in the past where this numbness came on very quickly, and they thought it was this separate disease, but in fact, it was this B vitamin deficiency from the levodopa. So that's something that we had to come up about. This is sort of version 2 of duodopa made by the same company called AbbVie, and they call it Vyalev. And what this is also levodopa, but it's something called phospholevodopa, which is highly concentrated. But instead of this requiring a tube that goes through the abdominal wall, what this is this is given subcutaneously. Now, for some reason, this is so new that the only pictures I could get of this was on a Japanese website. I couldn't find any pictures of it in Canada, but this is just being rolled out in Canada. It is not currently covered except with some private insurance. The medication has been approved by Health Canada. Ironically, what the holdup was that the pump was not approved. But at UBC, there is training going on about this, and we are trying to look for potential candidates. As I said, it's not quite ready yet, but it's very close to being implemented. So the way this works is you have this applicator, which has got this initially a tiny, when they start an IV, there's a needle that they remove the needle and there's a plastic cannula. So that's what this applicator is. You put it on the abdominal wall. It has this needle initially, and then it becomes a plastic catheter. And this highly concentrated phospholevodopa is infused in. And what this is this is actually a syringe. And what this pump does is it just slowly depresses the syringe. But it does require that people have the capability to draw up the medication in the syringe. And then this site may be moved every 48 hours. But the big benefit of this is that some of the complications that people have run into with the duodopa have been related to the tube that had to go through the abdominal wall. And there's been some cases where the tube has got kinked inside the gut and had to be replaced, or there's been a local infection around the site where the tube penetrated the skin to get into the gut. So the ability for this to be just under the skin, which doesn't penetrate through the abdominal wall, will be much safer. And so I suspect ultimately the duodopa will probably be replaced by ViaLev over the long term. Again, there may be other issues related to coverage and whether or not provincial plans are going to cover this. Because again, I think it's going to be approximately the same price, which is very expensive. I think it's approximately $60,000 a year. Don't quote me on that, but that's the type of the kind of approximate range of costs. And so the government is looking very carefully at this as to whether or not they want to support or cover this medication. The other thing that's kind of interesting is the duodopa, initially it was turned off at night. And now we have had some people, at least in our clinic, where we've had to ask for special permission to give the infusion over 24 hours. And what I think is interesting is that the ViaLev now is going to be given over 24 hours. I think they realize that the turning off the duodopa at night often resulted in people not sleeping well and wearing off at night, which is uncomfortable. So it's interesting. I think that the ViaLev is going to be given over 24 hours. So again, this is something that's just come on board, and you'll hear a lot more of it in the upcoming months and years. Now, this is something that is very interesting, and this is MRI-guided focused ultrasound. So this is a company called Insight Tech, which makes this slick movie. And what it is before deep brain stimulation, one of the treatments of Parkinson's was a surgical treatment where they actually went in and they nicked a tiny area of the brain to where the tremor and some of the symptoms were arising. So there was this part of the brain called the globus pallidus, and they would do pallidotomy where they would go in and make a little nick, and that was very effective. The reason why deep brain stimulation took over is once you nick something, you can't unnick it. But with deep brain stimulation, you can always turn the stimulator off. So that's why deep brain stimulation has removed the lesioning process. But we may see a reemergence of the lesioning, because another way to perform lesioning is to use ultrasound. So what they do in this procedure is they put over 1,000 ultrasound transducers on the head. And what they do is they essentially blast sonic energy, ultrasound energy, and they focus it into a tiny spot in the brain, similar to where they used to lesion before. And what they can do is they do this in the MRI scanner. And with the MRI scanner, there's a special MRI sequence where they can measure the temperature of the brain. And what they do is when they focus this ultrasound energy, they can slowly increase the temperature. And they can, as they increase the temperature, you get a point where the brain is temporarily inactivated. So let's say someone's got tremor and you increase the temperature and the tremor goes away, then you know you're in the right spot. And then what they do is they dial up the temperature even more, and then it causes a permanent lesion. And so this is now being approved by the FDA for essential tremor, which is another type of tremor, and Parkinson's tremor. Those are two of the only current indications, but this is being very actively investigated for other parts of the brain that might be very useful for Parkinson's. This is currently available in Toronto, and it's available in Calgary, but not in BC. And I'll mention more about that because one of my deadlines that I'm busily working on here in China is related to trying to get this technology here in BC at UBC. So I'll mention that a bit more. So that's what you've heard about. The other thing that's been very important that has been championed by my colleague, Dr. Cresswell, is the importance of the microbiome. And so one of the things that's been a bit surprising is this idea of a gut-brain axis. So we have trillions of microbes, bacteria, fungi, and viruses that live in our gut. And already it's been shown that certain bacterial species are affected or different in people with Parkinson's than others. This may contribute to intestinal inflammation. And it may also affect the ability of some people to respond to medications. And so this is very intriguing because it is possible to manipulate the gut microbiome, either through antibiotics or the idea of a fecal transplant. So what this is you would take a pill that would have the microbiome of a separate individual who doesn't have Parkinson's, and this may seed your gut with the new healthy bacteria. So this is a very active area of research, and it's being conducted in many places around the world, including UBC. And I think we'll learn a bit more about this. So I'll just circle back to when I was talking a little bit about the genetics. So remember I mentioned that one of the best things about the genetics is it gives you a clue as to what biological pathways were important. One of the big surprises that came out of the genetics was that some of the genes that were associated with Parkinson's were also associated with Crohn's disease, which is an inflammatory bowel disease. And so this was one of the clues that the gut and certainly intestinal inflammation may be important key component to some aspects of the disease, and many people think that the disease may actually start in the gut. And so this has caused an explosion of interest into the examining the microbiome. So again, I think we'll be hearing a lot more about this in the future. Now, what about looking in the future? So again, there's many exciting things that I think we could talk about, but I've chosen a small subset in the interest of time. So deep brain stimulation, again, is a very effective therapy. It's been around for decades now, and it's a very effective therapy. Interestingly, we still don't know exactly how it works. It seems to work by many different mechanisms. So even though the stimulation is occurring at one tiny area of the brain, it seems to evolve a whole network. So there's a whole, the brain works with multiple networks. And even though you target one specific node, it has very widespread network effects. So it's still being understood. Some of the recent advances have been that it used to be that once you had the electrodes placed inside your head, that you couldn't have an MRI scan. And this was a bit unfortunate because, if other diseases occurred, like let's say there was concern that someone might have a mini stroke, they couldn't have an MRI scan because they had these electrodes implanted. So this is now largely being solved. they have these, the concern is that if you use the wrong sequence, MRI sequence, that the electrodes could heat up with the energy of the MRI and heat up the electrodes and actually damage the brain. That was the concern. But now they've got these new sequences where that can be done safely, so that's very important. Many of you know that people had to have their battery changed every few years or so, and now that's been supplanted by rechargeable. The other important aspect was the idea of special electrodes for directional stimulation. So when the electrode is placed, there are actually several different electrodes that they can program so that they can switch which electrode is actually stimulating to get the best therapeutic effect. Where this is advanced now is they can actually point the current in one direction, and that may give even more flexibility to make sure that you get the best therapeutic effect. So I think that's been an improvement. The other big thing now is the so-called bidirectional system. So the original systems just gave stimulus. It was just pulsing and stimulating the brain. But these new systems can now record from the brain and then stimulate from the brain. And that might be important because you might want to know what is the brain state before you give the stimulus. So these so-called bidirectional systems are becoming very important. And this is, and then if be able to assess people remotely, that might be very helpful for people living in rural communities. So some of the parameters and so on could be transmitted over the internet, so they people don't have to come down to a central DBS clinic. And then finally, a thing you'll hear a lot more about is this idea of closed loop stimuli, or closed loop stimulation. Right now, almost all the DBS that's delivered, it's just doing this all the time. So it doesn't matter if you're sleeping or you're sitting on the couch or you're going for a brisk walk, it's giving the same stimulus all the time. But of course, that's not very natural because the body, ramps up things and slows things down depending upon what you're doing. So the idea of this closed loop stimulation is if you can sense what's happening in the brain, and if saying, okay, this person's active or the Parkinson's state seems to be a bit worse, maybe we should give a slightly stronger stimulus. Or the Parkinson's state seems to be a little bit better, we don't have to give as much stimulus. So this idea of sensing what's happening in the brain or how active people are, determining what's the best stimulus to give, and then giving the precise stimulus depending on the brain state. And this was originally motivated actually to preserve battery life in that, you didn't have to give a strong stimulus all the time if someone was asleep, for example. But what has been a very interesting observation is that because this is more natural, it seems to be providing even better results. And so I think this idea of closed loop stimulation, there's been lots of work done in animals on this, and we are starting to see clinical trials of this. So I think we'll be seeing a lot more of this in the future. So I would say that's one thing we're gonna see. There are a number of drugs that when we go to these international meetings of Parkinson's, where we are envious of our colleagues of access to certain medications that we don't have in Canada. Particularly, there's one called pimavanserin, and I think this will be particularly helpful. As many of you know, it is possible for sometimes with people with Parkinson's to get some aspects of psychosis, either things like visual hallucinations or things like delusions and so on. And we are kind of limited of the medications that we can use for that. The reason being is that the medications that psychiatrists would normally use for these types of symptoms, there are quite a few, but almost all of them worsen the Parkinson's. And the only ones that we have available now that work is one called quetiapine, and Seroquel is the brand name for that. And that is quite good in that it doesn't worsen the Parkinson's, but the psychiatrists don't like it because it's not very powerful. So it's not super effective, but it's safe for Parkinson's. So that's why we use that. There is one that's very effective, that's called clozapine, but unfortunately, very, very rarely it's associated with a fatal blood disease. And so if you're on that medication, you actually have to have your blood drawn every week for 6 months. And then I think it switches to every 2 weeks to make sure that you don't have this precipitous drop in your blood counts. And so it's not very convenient, although it is super effective. So I think we have a limited repertoire for this symptom in Parkinson's. And so this pimavanserin seems to be much safer and much more effective. And so I think that's one that we would certainly like to see here in Canada. Another one that we are seeing a lot of is subcutaneous apomorphine infusion. This is being used increasingly in Europe. It's a little bit like the Vyalev. It's the same principle, as I mentioned, of the subcutaneous, but instead of phospholevodopa, which is what the Vyalev is, this is a different medication. So again, I guess we'll need more experience to know the pros and cons. But again, we are seeing a lot of our European colleagues using this, and so at some point we would like to see these available in Canada. There is another medicine that's in the pipeline that seems to be generating a lot of interest. It's called buntanetap, and it was actually developed, I think, at NIH in the US. And it's an oral medication, and it seems to be very useful for inhibiting some of these toxic proteins that accumulate, not just in Parkinson's, but also in other neurodegenerative diseases, such as Alzheimer's and even head trauma. And so there is a phase 3 trial of this medication in Parkinson's. So we might be hearing a bit more about that. The other thing that we're going to hear a lot more, and you may have heard about this in the news, is this idea of repurposing of drugs. And in fact, we have some of the experts here in Canada. So Dr. Kalia at the University of Toronto, for example, is one of the experts in this. And what this is to go through, we have literally hundreds of thousands of medications that are available for different indications now. And because even though they're designed for one thing, the good thing about a drug that is on the market is that it's proven to be safe. There's been so much testing before any drug gets released on the market. It's gone through so many phases of testing that it's proven to be safe, and it's only extremely rarely that later on it's found that something that went through all the approval processes is found not to be safe, and the drug is pulled from the market. I mean, that happens very, very rarely compared to the hundreds of thousands of drugs that are available. So some people had the great idea of saying, well, if all these drugs are safe, instead of trying to build a new medicine from scratch, why don't we see if these medicines that are already proven safe but designed for something else also have benefit for Parkinson's? And so there's been a lot of interest in some of the new drugs for diabetes, like exenatide, for example. Some of these new diabetics drugs are being investigated because they seem, at least in animal models, to be very effective for slowing the progression of Parkinson's. And so there are some clinical trials underway looking at this. The other drugs that have been looking at that are leukemia drugs. And so some of these drugs are currently being investigated. And there's a number of clinical trials looking at this. But I think this whole concept of repurposing of old drugs is going to be something that we're going to be hearing about more in the future. Again, I mentioned that one of the key parts of Parkinson's is this deposition of this abnormal protein alpha-synuclein. And so there's a lot of interest in targeting whether or not we could see if we could get rid of the alpha-synuclein and whether or not that would help people with Parkinson's. And so this can either be done with passive immunization, where you give people monoclonal antibodies against the alpha-synuclein, or giving people immunization, active immunization, to try and have the body's own immune system try and prevent this accumulation of this protein. Now, a bit of a caution that this idea has been used and investigated in Alzheimer's for many, many years, and it still hasn't really borne fruit, although there is recently an approval of one of the Alzheimer drugs. But this concept is not new, but I think targeting alpha-synuclein specifically for Parkinson's, this is being very actively investigated. So we have our fingers crossed, but I would be a little bit cautious just because of the same principle has been actively investigated with Alzheimer's, with just, I would say, modest success. So everyone is always asking about stem cell therapies, because this in many ways is the holy grail. If part of the main problem of Parkinson's is that these dopamine cells die off prematurely, wouldn't it be great if we could reintroduce dopamine cells back into the brain? Unfortunately, that's a lot harder than it sounds, because if you introduce cells, generally you have to introduce stem cells and make them convert into dopamine secreting cells. If the cells replicate uncontrollably, well, that's cancer and that's a tumor. So you have to be very careful. But there are now 6 stem cells trials in the pipeline as of 2023. And so at UC Irvine, they are looking at this, and Blue Rock Therapeutics, they are looking at both phase 1 and phase 2 trials. They should start recruiting now in 2024. So I think this is something that we'll always hear about. Unfortunately, some of the prior companies that have tried this have all gone bankrupt for a number of different reasons. But this is certainly being actively pursued because it's so tantalizing, the idea of that, you've lost cells. If there was a way that we could reintroduce cells back, this would be obviously be an absolute game changer. So this is always going to be actively pursued. Gene therapy. So this is something that you may hear a lot about. So this involves introducing genetic material, either a new gene or more recently, very modern technology where they have gene editing tools. So if one has one of the genetic abnormalities that is associated with Parkinson's, could you reintroduce a normal gene if you have a abnormal gene that might be contributing to the Parkinson's? Or you could actually inhibit some enzymes that might be associated with degradation of dopamine. So these are the types of things. But there's actually some ethical concerns, of course. You're directly modifying someone's genetic makeup. And so obviously there's a lot of discussion about this. But if you look at clinicaltrials.gov, which is the kind of international area where any sort of clinical trial will be registered, it's a US thing, but basically almost all international clinical trials are registered there. There's 25 trials currently involving gene therapy and Parkinson's disease. So I think we're going to hear a lot more about this in the future. Now, here's something that's quite exciting, and that is, I mentioned before, the blood-brain barrier. And this prevents medications from getting into the brain. This is a new technique, actually, where what you do is you inject these micro bubbles into the blood, and then you apply ultrasound where these bubbles are at the resonant frequency of the ultrasound. And what this does is this opens up the blood-brain barrier slightly. And as I said, the blood-brain barrier is good news and bad news. The good news is it's there protecting the brain. But the bad news is if we want to deliver an important medication, it can be very difficult to get it into the brain. And so the ability to transiently and focally open the blood-brain barrier so that we could deliver medications, this may be extremely useful. Now, this won't be just useful for Parkinson's disease, but it might be useful for other diseases. For example, brain tumors. You can imagine if you have a toxic chemotherapeutic agent that you don't want to deliver to the whole brain because it might damage healthy brain tissue, but you do want to deliver it to the tumor, then the ability to focally open the blood-brain barrier around the tumor so that you can deliver this chemotherapeutic agent would be much, much safer than giving chemotherapy where it goes throughout the body. So this is something, these are the types of things. So as I said, we will be hearing more about this in Parkinson's, but just to give you a flavor about this, this was a very recent study published in the New England Journal of Medicine for Alzheimer's, but I think this principle will be important for Parkinson's. And what they did is they delivered this new medicine that's recently been approved, aducanumab, which is a monoclonal antibody targeting, instead of alpha-synuclein, it's targeting a different protein called beta amyloid. And what they did, and with this medication, only 10% of it actually gets into the brain because of the blood-brain barrier. So what this group did, which was quite clever, is they decided to open the blood-brain barrier on one side of the brain, but not the other side. And then they measured how much of this abnormal protein was accumulating over time using PET scanning. And that's what these two curves are. So this is over time. And this was the side that didn't receive the blood-brain barrier opening. And this was the side that did have the blood-brain barrier opening. And you can see the side where they opened the blood-brain barrier, this medicine was able to clear out the abnormal protein much more effectively. And so again, I think this is the type of thing that we will be seeing a lot more in the future, not just for Parkinson's, but for many brain diseases. There are some other ways to get circumvent around the blood-brain barrier, and that's using these new technologies called nanoparticles. And these are these very tiny molecules that may have very specific properties that can cross the blood-brain barrier. And we actually have some real experts at UBC in this. So this is something that I think we will be looking at. And this is something that we're actually actively involved in. So remember when I mentioned the ultrasound, so when you see the ultrasound on TV for Parkinson's, it's usually the first instance where I mentioned that it heats up the part of the brain to introduce a tiny focal lesion, and that's high intensity focus ultrasound. Medium intensity focus ultrasound can open the blood-brain barrier. But there's a lot of interest now in low intensity focus ultrasound. So this does not cause a permanent lesion, but it may transiently modulate the brain. And by low intensity, I mean very low. Like this is lower intensity than is used for pregnant women looking at their fetus. So this is very low intensity. It can go through the skull and it can modulate some parts of the brain. And again, this might be a very effective therapy for Parkinson's. It's extremely new, and we're actively pursuing this. The benefit of this compared to other technologies is the ultrasound can penetrate deeply inside the brain. And if you have several of these transducers, they can focus it into a spot. So this allows us, it's a bit, when you think of it, it's a bit space age. It allows us to activate an area deep in the brain through the skull without an operation. And so I think this is something that's very exciting and will help us understand the disease better, and it may open up new therapies. And just to give you a flavor of that, one of the things that we're actively pursuing now is, remember I mentioned we were trying to get this high intensity focus ultrasound here at UBC. And so we are putting in a large grant from UBC to try and get this technology here at UBC. And the people involved are myself from neurology, Professor Vila Rodriguez from psychiatry, and our new functional neurosurgeon, Dr. Lang. And so the three of us are trying to put a large grant together to bring this technology here. And in our own personal lab, we have now looked at this low intensity focus ultrasound. And I'll give you a flavor for that. We recently got a grant from the US Focus Ultrasound Association. And the story is the following. Um, Remember I mentioned for the high intensity focus ultrasound, it's used either for essential tremor or Parkinson's tremor. And the target that they're looking at was this area of the brain, which is called VIM thalamus. It doesn't important, but what they are using, they noticed that when they targeted the same area for both essential tremor and Parkinson's tremor, it didn't work as well for Parkinson's tremor. And it's unclear why. And an observation that is being made is when they look very carefully at where the lesion was delivered, if the lesion involved this adjacent area called the ZI, they got much more effective treatment of the Parkinson's tremor. So what we are doing with our grant is to use the low intensity ultrasound, which is not a permanent treatment, but a temporary treatment, to compare this area, the traditional area, with this new area. And then if we show that this new area is more effective transiently, then that will provide support for clinical trials that may provide the permanent lesioning. So that's one thing. And then we also have another grant where we're targeting two different areas of the basal ganglia, where people would come in and they would get the ultrasound daily for a couple of weeks to see whether or not this might be a novel treatment for Parkinson's. So again, this is something that we're currently pursuing. Another thing that is going to be important, and this again is not just related to Parkinson's, but is related to medicine in general. So one thing that unites all doctors is they'll tell you the following. They'll say, we love interacting with people with our patients, but we hate all the paperwork that's associated with it. And so there's an old adage in medicine, if it's not documented, it didn't happen. So many doctors will grumble that a lot of the things, there's quite a tedious process to meticulously document everything that happens in your interaction. So one thing that is becoming very exciting is this idea of so-called large language models, or chat GPT. And the idea would be the following, is you would get consent from the patient. And what you would do is you would just have a microphone there, and then you would be interviewed like you normally would be. The doctor may say, Mrs. Jones, how are you doing? And how has your tremor been? And have you had any other problems? And so on. And with the normal conversation that's had. But what these new technologies can do is they can now take that conversation, convert it into text, and then rearrange that into a clinical note. So the clinician doesn't have to spend much time rearranging, the information that was obtained to make it into a clinical document that becomes part of the legal clinical record. So the ability of these um, large language models or the artificial intelligence to rearrange this kind of freestanding interaction into a specific clinical record will be absolutely game changing. Obviously, there's risks involved that we would have to ensure that everything is completely accurate. But I can tell you that this is something that's exploding, and we currently in the Division of Neurology are looking at this. And in fact, we are just about to implement this for Parkinson's as a pilot study to see whether or not this may make it more efficient for you to see your clinician and more natural. Another thing that we're looking at, which I think you're going to hear a lot more, is automatic monitoring of the disease. When you go in and see your doctor, very often they are asking you to perform many motor tests, such as tapping your fingers or doing this, or these types of movements. And these are ways to assess the disease. And there is something called the Unified Parkinson's Disease Rating Scale, the UPDRS. The thing is that these are semi-subjective. I mean, obviously, trained clinicians do this day in and day out, so they're very consistent. But it's not 100% quantitative. And so there's a lot of interest of whether or not we could be a little more accurate with this. And why is that important? Well, if you're trying to assess a new therapy and you want to see, okay, we're going to give drug X to these people with Parkinson's and placebo to these other group, we want a very accurate way to see how or if the disease is progressing. And if you have these semi-subjective scales, you have to recruit more and more people to be able to average out the noise, if you will. But if you have a very quantitative way to measure this, this may allow us to do smaller trials more efficiently and more accurately. And the other thing, of course, is you often may not see your clinician until every 6 months or even every year. And clearly, people know that the disease fluctuates hour to hour. And so it would be extremely valuable to be able to monitor people continuously. There is a lot of interest now in wearable sensors. I think you could probably get someone to wear an Apple Watch or a Fitbit, for many months. Probably less so that you would get them hooked up to 10 different sensors over their body. So that's a bit of a challenge. So there also is some interest in video monitoring. And so the benefit of video monitoring, just as since we're on Zoom here, is that it could be done remotely, and this is, I think, a big boon for people in rural communities where people can be very accurately assessed remotely. And if we had ways to automatically assess people, it empowers people with Parkinson's to say, I want to know how bad my disease is today compared to yesterday. If there were automated ways where they could just go up to a screen and do this and do the standard moves that you do with your clinician, and it would automatically tell you, oh, this is how you are today, and you could compare, how you were a few days ago or last week or last month. I think this will empower people so that they're not reliant on their clinician to tell them how their disease is progressing, that they themselves would know. And we think this would streamline the visits. So if we can get a computer to automate some of these things, then it gives you more time to discuss things with your clinician, things that you're concerned about. Instead of them, if for example, in the waiting room, if you could do some of these tests beforehand and it would automatically grade your aspects of your disease severity, and that report would be available to your clinician, then it would give more time for you to discuss other things that might be that you feel are important with your clinician. So I think that's something that will be helpful. And the other thing is it may allow for non-expert disease assessment. So there are only a finite number of movement disorder specialists in the country, and so it may be very challenging for your family doctor to know how things are progressing. And so if you had a way to automatically assess people, this might allow other clinicians who are less experienced with Parkinson's. Now, just give me 1 second here, Kyle. I'm just going to stop sharing just for a second because I realize that you have to optimize for a video click here. Okay, can people see that now?
We
Okay.
can, Martin. We are
Okay.
out of time, so I'll just
Oh,
let
okay.
you know that as well. So
I'm
if
sorry, I didn't. Okay.
I gave you a really challenging request, didn't I? 10 years review and 10 years looking into the future.
Okay. Well, I'm happy to. I mean, I've got a couple more slides, but that's it. Or do you
Please.
want me to stop now? Or
Well, can you conclude in about 5 minutes, do you think?
oh, absolutely. Yeah, I'm
All right.
near the end. Sorry,
All
my
right.
apologies. I did down my phone. Um,
It's fascinating, and I couldn't interrupt. So,
Oh, I'm
but
sorry, I didn't realize. So this gives you some idea of some of the things where we can take a video and automatically extract out, how people are doing. So you can see here, we can zoom into the hands automatically and see how well they're performing. We can automatically assess their gait. So this is all done with artificial intelligence. Just from a video, we can extract out how people are walking. We can assess their face, which is very important for screening for things like depression. So we're looking at that. And we're actually looking at eye movements because there are some suggestions that we can measure some aspects of dementia with eye movements. And we can look at things like dyskinesia with our colleagues in Korea. And I'll skip that. And that's me done. So sorry, I hadn't appreciated I was over time.
That's all right. Didn't really set up a way to warn you, and it was so fascinating. I didn't want to interrupt either. As I said, it was very, very challenging task that I asked you to address. And I think you did it in it was incredible. So thank you very, very much on behalf of all of us here today. I see hands clapping, applause from the audience. Unfortunately, it means that we can't spend time on Q&A because we do still have the business meeting to get through.
Okay.
So if there are any really burning questions, if people would like to direct them to me in email, I'm happy to follow up with Dr. McKeown in a few weeks when, oh, am I going to be here? Yes, I am, in a few weeks when he returns from China. And also we will be posting this recording on our website probably a week to 10 days after today. So you will be able to pull that up and review it. There was an incredible amount of information, Martin. And it makes me so proud to and humbled to have worked with you over the past 10 years. And I will keep an eye out for all these exciting new developments as time goes forward. So thank you once again. You're just such a boon to the Parkinson's Society and to all the people affected by this disease. So thank you very, very much. And please, I hope you can go to sleep after this and get rested for.
Okay. Again, my apologies for being over time, but thank you again. And
no, but I couldn't interrupt. It was just so fascinating. So thank you very much, sir.
Okay. Good to see everyone. Thank you. Bye-bye.